All right. Hello, everyone. Welcome back to Neurospicy Nursing. Today's lecture is on the cardiovascular system. We are also going to talk about the just kind of overall anatomy of the heart, as well as I'm going to go and finally explain what that prolonged QT interval is. And then we're going to go into some of the more common disorders that we're going to see with the heart. All right, so the anatomy of the heart, it has three different layers. We have our epicardium, our myocardium, which is the middle. It's responsible for the actual um, muscular pumping action of the heart. And then we have the endocardium, which is that thin layer inside of the actual uh, atriums, ventricles, and then as well as for the valves. The epicardium is the outside layer, and then you have your pericardium, which is the kind of the entire thin sac that encases the heart. When we talked about for the infection lecture, pericarditis, the pericardium, so that thin, again, that thin layer is what is infected when we have pericarditis, or in ineffective pericarditis is another name for it. So, our heart has four chambers, right? We have our left and our right atrium. Our right atrium is going to take in deoxygenated blood. It's going to push it into the right ventricle. That right ventricle is going to push it out into the lungs through the pulmonary artery. Remember, arteries are going away from the heart, veins are going towards the heart. So, pulmonary artery for oxygenation. Um, for the actual oxygenation portion of how um, we get from deoxygenated to oxygenated blood is going to be in the next lecture, the respiratory lecture. Um, since I want you guys to know the anatomy of the lungs too when we're going over that, so it makes more sense. Um, and then after we go from the lungs, we're gonna take the pulmonary vein back to the heart. It's the only time our veins and our arteries are switched is when it comes to the pulmonary system, into the left atrium, and then the left ventricle is going to shoot it out to the aorta, and then the rest of our heart, or rest of our body from the heart. All right, don't forget about your valves either. So your tricuspid, pulmonary, mitral, and aortic valves. This is the areas in which we have to listen to when we're actually doing our assessment. And then in the middle, we have Erb's point. So when we're talking about the heart, right, we have a few things that we have to keep in mind um, for like lab values, right? We have our cardiac output. So this is based on the heart rate and the individual stroke volume. And it is normal. The normal range is going to be 4 to 8 liters per minute. Now, if somebody has like heart failure, they have, you know, a risk for decreased cardiac output. You've probably heard that nursing diagnosis before. So that means that they have a lower range of how effectively their body can pump that blood. Contractility is how strong that heart muscle is and whether or not it's effectively contracting to get blood to move to other portions of the body. Preload is the amount of blood that's left in the ventricles at the end of the diastole. And afterload is how much the heart has to work to force the ejection of blood into another area during systole. And then ejection fraction, it's going to be the percentage of blood that's left in the ventricle with every single contraction. So the normal range of that is going to be 50 to 70%. It sounds kind of low, right? But people with heart failure are going to have, or if they just had a heart attack, they'll have a low ejection fraction. All right, so hemodynamics, remember, this is a little bit more of a visual thing, but for our hemodynamics, 4 to 8 liters is going to be normal for cardiac output. And then we have our central venous pressure. So it's the actual amount of pressure in that vasculature, um, and the amount of actual pressure of blood returning to the right atrium is specifically what we're talking about when we're talking about central venous pressure. Think central means in the middle of your body, just like how when we have central cyanosis, it's in their trunk. Same thing here. Mean arterial pressure, you guys have probably seen this when you're taking blood pressures, or you should at least be writing these down in the charts. But our maps are mean arterial pressure. It is 70 to 100 millimeters of mercury. And we need at least 60 millimeters of mercury to make sure that we're perfusing our vital organs. Anything below that, it's dangerous. And then another thing I just wanted to mention is for our cholesterol, we have good and bad cholesterol, right? For our good cholesterol, it should be greater than 40, at least if you're a female, and if you're a male, at least greater than 55 milligrams per deciliter. Bad cholesterol, it should hopefully be less than 100 milligrams per deciliter. Um, we want to have low LDL and high HDL. Then when we're talking about BNP, this stands for brain natriuretic peptide. This helps rule out heart failure. So if there's a presence of this, a high presence of this, I should say, because we want it to be less than 100. If there's a high presence of this, it's very indicative of heart failure. Um, and then we have D-dimer. We normally use this for testing for clottings. Like if someone is coming in with chest pain, for like an NST or for a STEMI or something like that, this is going to help determine, if there is a clot. So our heart also has a conductive system, um, and it's why individuals who have heart problems can get pacemakers, because there are actual nerves that are um, responsible for regulating the contractions of the heart. So our SA node is extremely important. It's our primary pacemaker. So when an individual has an SA node issue, this is when they get a pacemaker, like a pacemaker. And it's going to generate impulses at 60 to 100 beats per minute. Another reason why someone might get a pacemaker is if they have really aggressive AFib. It's going to kind of prevent their heart rate from spiking too high because the pacemaker will only allow it to go to a certain number. So if they have it set at like 70 beats per minute, it's going to go at 70 beats per minute. And then you have your AV node. It's between your atrium and your ventricles. Um, it is your backup pacemaker. So it takes over once your heart rate kind of drops to 40 to 60 beats per minute, or if your SA node fails. Then you have your bundle of His, which branches out into your bundle branches. You have a left side and a right side. Our bundle branches are going to shoot that impulse down to our Purkinje fibers, and then our Purkinje fibers are going to fire at a rate of 30 to 40 beats per minute. And that's in the event of both our SA and our AV node fail. So it's the contingency plan of those two nodes. Okay, so this is just a little bit of an introduction into how an EKG looks. We're going to go again fully in depth into the QRS complex in this video, as well as talking about the QT interval, since it is important, since we've talked about several medications at this point that have prolonged QT intervals. So just know that the intervals, there's a range for them about how many seconds that they should take. And based on that normal range and the heart's normal sinus rhythm, we can know whether or not something is prolonged or shortened, or if something is elevated, like in a STEMI. So, when we have a system malfunction, like when our heart is failing to pump blood, like in congestive heart failure, we have some risk factors that are going to be associated with that, like AFib or a dysfunctional heart valve. You can also have um, acyanotic heart defects that can cause this as well. Um, Obviously, coronary artery disease, that narrowing of that vasculature can also cause it, and uncontrolled hypertension, um, for kind of the same reason as coronary artery disease, that constant vasoconstriction of that vasculature, pressing up against those walls, it's going to cause um, fluid to go into what we call third spacing. So fluid that's going to be in places it's not supposed to be. So overall, heart failure is a cardiac disorder that is going to impair the heart's ability to eject blood out of the ventricles, which means that the heart is not going to get enough blood, and then the body is not going to get enough blood. Um, we can see this in a few different ways. So I talked about that BNP, um, that natriuretic peptides. They are a biomarker that is actually going to be released when the ventricle stretches because of fluid overload. Um, Down below is kind of the range of what we're expecting to see for heart failure. So less than 100 is expected. If you have greater than 900, that is severe heart failure. Um, Chest x-rays is another thing that we can do to show like whether or not the heart has been enlarged, or um, if there's any pulmonary infiltrates. Sometimes they might do like um, CTs or MRI to see about the blood flow, but echocardiograms are another great diagnostic tool for this, for actually measuring the ejection fraction. And then when we're talking about heart failure, remember that the best way to monitor the fluid overload is going to be weighing themselves every single day, and a weight gain about 2 to 3 pounds in 24 hours is alarming. Um, and also 5 pounds in 1 week, or over 5 pounds in 1 week, is also alarming. All right, so heart failure also has left-sided and right-sided. So left-sided heart failure is going to happen when the left ventricle has become stiffened and it can't eject or properly fill up with blood. So the fluid is then going to back up into the lungs. These individuals are going to have dyspnea, orthopnea, which is they have trouble breathing while lying down. These are the individuals you'll see who have to sleep up with a bunch of pillows underneath their back. Rails or crackles, that fluidy sound that you get in your lungs. They also have a chronic cough. They may have bloody sputum, and they can have cyanosis, as well as um, issues with their um, just, overall oxygenation. And when we're checking their SpO2, it's going to be on the lower side. So right-sided heart failure is from when it's most times it's because of left-sided damage. Oh, I did also forget to mention that left-sided heart failure, that dyspnea, chronically getting lung infections. Another way that people can get it is from those acyanotic birth defects. They shunt oxygenated blood back into the right side of the heart, and then it puts too much pressure on the lungs. Um, and that's what give you those heart failure symptoms on the left side. So left side's always going to be related to the lungs, that pulmonary congestion. But it's going to shunt to the right side, put too much pressure on the lungs, and then it's going to have a hard time because it's going to keep circulating. No matter what you do, it'll keep circulating back into the lungs. Right-sided heart failure, again, often a result from left-sided heart failure. It's the backflow of fluid into the actual venous system at this point. So right side, rest of the body. This is when you're going to see your jugular vein distension. You're going to see your pitting edema. Remember, pitting edema, a +1 is going to be 2 mm, +2 is 4 mm, +3, 6 mm, +4, 8 mm. You're also going to see jugular vein distension, so that bulging neck vein, because of that pressure on the vasculature. Also, we're going to see ascites, so really all of the third spacing at this point. Um, Ascites, This is when your hepatic portal vein, again, it is a lot of pressure on the vasculature system. Um, there's a lot of pressure on the hepatic portal vein that's really responsible for your liver getting nutrient-rich blood. So, because that is going to become narrowed, it's going to be harder and harder for the liver to get blood, and then it's going to cause the liver to enlarge. And then after the liver enlarges, and again, since you have fluid overload, that it's almost like a wet paper straw is really the best way to explain it. When you leave a wet paper straw in a cup for too long, it's going to soak up the water. Our vascular system is going to do the same thing with the blood that's shunting back into the venous system. It is going to suck up that water and then it's going to move outside of where it's supposed to be. That's what we get third spacing. So it's going to move out into the abdominal area, and this is when you're going to see them do those drainages where they put the needle into the side of someone's stomach and then they drain all that yellowy fluid. These are the individuals that you'll see with the really, really round bellies, but very, very narrow legs. All right, so coronary artery disease. This is commonly caused by the buildup of plaque in our blood vessels. It's something called arteriosclerosis. That narrowing is going to limit blood supply to the heart. There are risk factors like hypertension, smoking, obesity, and if someone has elevated LDLs, so that bad cholesterol. Also, something that's going to be seen kind of with coronary artery disease is angina, so that chest pain. Angina is normally associated with a low amount of O2 to the heart, with at least one of the major arteries starting to narrow. There's multiple different types of angina, but stable angina is going to be the one where we give nitroglycerin as a treatment option. They can take nitro 5 times within 5 minutes of each other if they still have chest pain, up to 3 times. After 3 times and they're still having chest pain, they should be going to the ER because it's possible that they could be having a heart attack. Um, Unstable angina is going to be the type of angina that causes like a pre-infarction type state. So right before you, not, I don't want to say right before you're about to have a heart attack, but it's likely that you are probably going to have an MI because of the unstable angina. They're relatively well associated with each other. The other thing to keep in mind is that this is going to occur also at rest, and sometimes nitroglycerin isn't really going to help. And then there's variant, which is it also occurs at rest, but it's just based on the spasms of the arteries, less about, yes, kind of narrowing, but less about narrowing sometimes. All right, so MIs. So myocardial infarctions, these are our heart attacks. They are a blockage of at least one artery of the heart, either because of a blood clot or rupture of that arteriosclerosis plaque. And it is a medical emergency, whether it's an NSTEMI or a STEMI. Some individuals get a crushing pain on their chest, where they may say like either I'm about to die and it feels like an elephant is sitting on my chest. They actually get a side effect of a heart attack is this impending doom. They also may get pain that radiates up to their left jaw, left side of their jaw, their arm, or in their back. And then these patients are going to be very diaphoretic. Remember, they're stressed out. Their body's going into fight or flight mode, because their heart is having a lack of oxygen, right? Also, women are going to have some atypical signs of heart attacks. So, women have epigastric pain, very, very similar to indigestion. Or they may have, like, I think another one I saw was they get earaches or headaches, which that can actually delay the diagnosis of a heart attack in a female. So, keep that in mind. Women have a little bit atypical symptoms when it comes to myocardial infarctions. So, when we're talking about MI, we're going to go over that on um, the actual EKG stuff in a little bit, but a STEMI is based on an ST elevation. I know you guys don't know what ST is yet, but just keep in mind ST elevation is a type of myocardial infarction. That means that there's a complete blockage versus an NSTEMI. There is an ST depression, which means that there's going to be a partial blockage. And then down below, there's some immediate treatment options that we're going to do. Morphine, it's going to help reduce pain that they're feeling and their anxiety. O2 is going to help supply oxygen back to the heart. Nitro, it's a vasodilator. And then aspirin, if, it is blood clot related, it helps the platelets not stick together. All right, so cardiac biomarkers, there's two that's going to be very important. Troponin, there's two different types of troponin, but just know that troponin is a cardiac biomarker. And then CKMB, creatinine kinase. This is not the same creatinine that we see in our kidneys, technically. What we see when we're doing RBU and creatinine, that is a byproduct of this enzyme, this creatinine kinase MB. Um, and when we excrete it, it turns into the creatinine we see in our kidneys. So, troponin, super important indicator of an MI because when there is damage to the heart muscle, it's going to release troponin. This protein is specifically released when there is damage to the heart muscle. So it's detected within 2 to 6 hours of your kind of MI start symptoms. It can peak for up to 24 hours, and you can have that elevated troponin for up to 14 days. So if you're on CVICU, let's say your patient had a heart attack 3 days ago, it's possible that um, troponin level can stay elevated or continue to get higher for the next few days. Creatinine kinase, it is an isoenzyme, but it's going to be a little bit less reliable than troponin just because it's more generalized, indicates overall damage of musculature rather than just heart musculature. And then we have myoglobin. It's found in your cardiac and your skeletal muscles. Again, not a specific indicator, but a negative result can actually help rule out an MI. It's also going to have the highest and lowest, or the fastest rise and fall. But again, when we have an MI, we want to have a more negative result of this. All right, moving on to the next thing. I want to go over our full cardiac assessment before I go into that QRS complex, um, just because even though it is important to understand the QT prolongation for Zofran and some of our antibiotics that we've gone over so far, it's going to be less important than this information when it comes to your tests, um, for health assessment at least. I want you guys to know this more and then just kind of think of the other thing as a resource to know the why behind the what, and why there's so much monitoring going on with those certain drugs that prolong our QT interval. So, again, don't forget your heart is a muscle, so you do have to make sure that you are keeping an eye on it. Just because you're a nurse does not mean that, you have a healthy heart, right? We don't always have good habits. And nursing school isn't always the greatest, and maybe we like to go to Chick-fil-A a little bit too much. And that's okay, but everything in moderation, right? If we tell it to our patients, we should also be following the same rules. Um, okay, so our hearts, they are a mechanical pump, right? And they have an electrical conductive system to them. We have systole and diastole. The best way to kind of think about these words that you've definitely heard before, diastolic, systolic, like when we're talking about blood pressure. So our systole is going to be that lub sound in the lub dub when we're talking about the normal heart sounds. Our S1 is the lub, our systole. So this is when our ventricles are contracting and ejecting that blood. So systole is squeezing. Diastole is the relaxation, and they're allowing the chambers of the heart um, to fill up with blood. So diastole is that decompression. Again, we're going to look at stroke volume, cardiac output, and ejection fraction. They're all super important when we're talking about the heart. Okay, going back into this electrical conduction, please don't forget SA node, AV node. They're very, very important for the pacemaking of the heart. All right, so when we have a patient that's coming in and we are suspecting some sort of maybe cardiac related issue, um, or they're going to be at risk for cardiac related issue, we need to take a couple things into account. Obviously, one of the first things we're going to ask, are they having any chest pain? Pain is our fifth vital sign. So that is going to be one of the first things that you're going to ask if they're coming into the hospital with any sort of cardiac related symptoms. Shortness of breath is another one that we're going to ask about because that could be indicative of heart failure, fluid overload, those sort of things. You also want to know their lifestyle history. Do they exercise? What's their diet like? Do they take in a lot of alcohol? Do they use substances? Are they a smoker? Do they live in an area? And this is very important when we're talking about, you know, those social determinants of health, right? And how we can advocate and make sure that we are bringing more, as the ethics in nursing say, justice to our patients. If they live in an area that is heavily polluted, or if they live in an area where the housing maybe is not the best, or they have asbestos in the area, those individuals are going to have damage to their lungs. Some of them also, if they are 75 and they're still working a blue collar job because they can't afford to live in the area, um, they probably have other comorbidities going on, like hypertension. That's a lot of stress on your body, especially doing a blue collar job for that long. So other things, like things that you may not think of, can be related to your heart history. Or do they live in a house that was created before we put more restrictions on the use of lead in a home? Another thing to think about. Because there are still houses that are not renovated that do have lead-based things in them. Okay, so family history is another thing to keep in mind. If you have a family history of heart conditions, heart failure, um, COPD, or um, if you have a family history of heart attacks, those are all things that you need to keep in mind. High blood pressure as well, or high cholesterol, all things that you should keep in mind. And then again, that social and cultural consideration, making sure that you get to know a little bit more about your patient, right? If your patient, let's say, needs a new heart valve, well, the heart valves that we use for heart surgery, are normally derived from pigs. So someone that is of the Muslim faith is not going to use a pig-derived heart valve. And then also keep in mind that, again, we've talked about it before, food is cultural. Some cultures, may have quote unquote unhealthy foods. doing quotations here that you guys can't see, but you have to make sure that you're still being respectful, and we're going to educate them to do it in moderation. If they eat it 7 days a week, let's cut it down to six. We'll reevaluate in I don't know, 2 months and maybe cut it down to five if we need to. So it's all about harm reduction. Okay, so based on what your eyes can see is the first thing that you're going to do when you're doing your assessment. We're always going to inspect, and then we're going to auscultate and palpate unless, palpate and then auscultate unless it is your GI tract. Then you're going to auscultate, then palpate, because you don't want to move around any stool or gas and give yourself a false reading. So when we are looking at our neck um, vessels, we are expecting that there's no super bold, very obvious distension of those veins. Um, Also, again, we talked a little bit about it before, but JVD is related to that central venous pressure being increased, and it's a very common sign of fluid overload. But again, it's going to be very, very noticeable. They have a very like visible pulsations in their neck, and then that vein is protruding out. All right, when we're looking at the anterior chest, so the front portion of the chest, they should have symmetrical chest movements. Also, if someone doesn't have symmetrical chest movements and their breathing seems a little bit off, it could also be a pneumothorax. Again, we're going to talk about that in respiratory, but that's another reason why we're not going to have symmetrical movements. So another thing that you're going to do is you're going to look at the PMI. So midclavicular line, fifth intercostal muscle, fifth intercostal space, I'm sorry. And if they're littler, like little kid, it's still midclavicular, but it's fourth or third kind of intercostal space. It may be better for you to hear. So there can be some visible pulsations at the maximum point of impulse. I mean, it is right over that left ventricle, which pumps blood to your entire body. So it makes sense why you would be able to see pulsations. However, if they are prominent, very aggressive pulsations, that means that they most likely have an enlarged heart. Remember, your heart should be about the size of your fist. Um, so that's especially in that left ventricle, that enlargement of that musculature around that left ventricle. So that's when we see the very prominent thrusting of the PMI, that's another thing to keep in mind. You can see that on imaging. All right, so for perfusion, when we do our pulses, remember when you test your pulses, you're going to test them at the same time, bilaterally, left and right. The only time where we're not going to do this, please, please don't do this. Do not palpate the carotid arteries at the same time. You are going to stimulate that vagus nerve. You are going to reduce blood flow to the brain. You are going to cause your patient to pass out. Don't do it. All right, so we have our brachial pulse. Remember, this is the one that's very important for when we're taking a manual blood pressure. That cuff is going to line up with that brachial artery. So that is going to be in line with your pinky. And then we have our radial pulse, which is in line with our thumb higher up on our wrist. We have our femoral pulse, which is in that groin area. Your femoral artery is huge. Any damage to this artery is bad. Very, very bad. They have minutes. Okay, and then we have our popliteal pulse that is going to be behind the knee. Our posterior tibialis, that is kind of right behind that arch, where it's not quite the heel, just slightly above the heel, right behind that inner ankle. And then we have the pedal pulse, which is right on top of the foot, kind of in line with our third and second toe. And then there's a grading scale for this as well. We should be expecting to feel a +2 pulse. Bounding or diminished are going to be a little bit on the unexpected sound. There's also a +4. If you ever feel +4, they're probably about to start crashing. Very bad. But diminished in our older patients is going to be a little bit more normal, especially if they have a ton of comorbidities. So if you just want to make sure that it's, functioning well, you can get a Doppler. If it's 0, you should be getting a Doppler, um, and checking for proper blood flow. All right, so for the auscultation, we have our very specific landmarks. I didn't mean to put the 3 over there. Sorry, I put one on there twice. I kind of messed this up. But we have our aortic, so sternal to the right on the right-hand side. So when you're listening, it's going to be your left. Mid-sternal to the right, second intercostal space. Pulmonic, same intercostal space, but to the left. Erb's point is going to be still on the left-hand side, third intercostal. Tricuspid is just slightly below Erb's point, kind of in that fourth intercostal space, but inching a bit closer to the midline of the clavicle. And then mitral, this is our PMI, is mid-clavicular, right-hand side, fifth intercostal space. So, when we are listening for our normal S1 and S2, these are our high-pitched sounds. We're going to be using the diaphragm of our stethoscope. That is the bigger side of it. If you're listening to clicks and rubs, those are abnormal heart sounds. They are also best heard with the diaphragm. The bell is for our low-pitched sounds like our murmurs. Like if they had a acyanotic defect, they could have a murmur. Or our S3 and our S4 sounds. Do remember that, well, S3 is very common in um, fluid overload, but remember, pregnant women later in pregnancy, it's relatively normal for these individuals to have an S3 because of the increase in blood volume circulating in their body for baby. Okay, also don't forget S1 and S2 are going to be heard before S3. And then S4 is heard before S1 and 2. I know it sounds so silly. But S4 is a kind of like a early systole and S3 is a late diastole. Um, okay, so again, just so you guys remember, lub dub is what you're expecting to hear. S1, closure of the mitral and the tricuspid valves. So our fourth and fifth intercostal spaces is going to be best heard with the diaphragm. And then our S2 still best heard with diaphragm, but it's the aortic and the pulmonic valves closing. Okay, so an S3 apparently sounds like Kentucky, um, S1, 2, 3. It's kind of like a sloshing sound. It's literally just a really quick extra beat most of the time when you hear an S3 sound. Because of that fluid volume overload, it's going to push out blood and then whatever's kind of left in the heart, or kind of just float in from the ventricle, it's going to make more space by pushing it out again. Um, some children have S3, again, pregnant women, pretty normal. Some athletes also have S3, but that is less from fluid volume overload and just the intensity in which they work out their muscle. And then again, in when we see in adults, it's pretty indicative of heart failure. S4 is supposed to sound like Tennessee 4, 1, 2. There's also a mnemonic of a stiff wall, so it's that late diastole. I think I switched those, maybe. I think so. Yeah. Late diastole. Um, it's from pressure overload. It's always relatively associated with aortic stenosis, which is a type of heart defect, ischemia, so the lack of blood flow to an area, and it's always going to be pathological based. It's not just based on, um, it's some sort of damage, right? It's not just based on the amount of fluid volume. Okay, so clicks, snaps, and rubs. Clicks, they are a high-pitched, sharp sound, like if you have a mitral prolapse. Snaps, they are a high-pitched opening. It literally sounds like a snap, because it's pushing a lot of pressure onto that incompetent valve and it's forcing it to open, like in mitral stenosis. And then rubs, they're a scratchy sound. It really sounds like your hands are being rubbed together, and that's pretty indicative of pericarditis, that inflammation of the lining around the heart. Okay, so here's a little mnemonic I like to use to kind of remember the different heart sounds that you may hear, and it's script. So it's going to be broken down into site, character, radiation, um, as in like where does it move to, intensity, pitch, whether it's high or low, and then the timing. Is it diastolic or systolic? So if I were doing like mitral stenosis, it's going to be best heard at that PMI. It is going to be kind of a blowing sound. It may radiate, but it's going to be best heard. Um, wait, did I say mitral stenosis? I don't remember what I said. I think I'm doing aortic regurgitation. Um, it's blowing, and then if the patient is leaning forward, you will be able to actually hear this better. Um, the intensity, it's kind of based on like how loud it sounds to you. 6 is going to be it's like super loud, very aggressive. The pitch, high or low, if it's aortic regurgitation, it is going to be a, I'm gonna let you guys write that down, the answer, and then I'll put it in the description for you guys. Okay, so, again, this is left-sided heart failure versus right-sided heart failure. Don't forget third spacing is very common in right-sided heart failure, and then ascites is because of that pressure on the hepatic portal vein. Okay, so I actually want to talk about shock here. So shock commonly is going to happen when there's widespread decrease in tissue perfusion. That's going to lead to cellular necrosis, right? The tissues are going to die off. Or they can be like really, really badly damaged. So we should be attempting to restore perfusion by either administering IV fluids, giving vasopressors, or sometimes you can give atropine or epi in cardiac emergencies to help bring up someone's blood pressure. But make sure that the most important thing is that because shock has an underlying cause. Like you can go into septic shock, you can go into shock from hemorrhaging. So you have to make sure that you treat the underlying cause because just administering IV fluids and giving vasopressors, it's not going to fix the problem. Okay, and then AFib, don't forget it is an electrical conduction problem, and it leads to the irregular rhythm of the heart rate, and they're actually going to have no P waves. We're about to talk about this, I promise, right after this. And then hypertension, it's another chronic condition that you're going to see very, very commonly. It's chronically elevated blood pressure. Don't forget that they need to have a trending increase in their BP of over, it's going to be 130, kind of over 90, because now the documentation is saying that anything below 120 over 80 is normal, above 120 or 80 is pre-hypertensive, and then hypertension 1 is going to be 130 over um, 90. But again, trending, if they're stressed out and in pain, that BP is going to be different, and it can be higher, but trending upwards and kind of staying there. All right, so here is your guys' case study for this lecture. I'm gonna give you guys a minute to go over that. All right, so this patient states that his toe is really, 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 really hurting when he tries to sleep at night, and he's now noticed that he's a very large ulcer on his toe. He rates that pain score of an 8 out of 10. When we are looking at an individual's legs and we see like their skin tone is uneven, they have a shiny spot, or maybe they have hair loss. That's indicative of some sort of cardiac problem. And it's also a sign of poor perfusion if they have like, let's say all of their hair on their calf, but none of it on their shin, but it doesn't look like they had any injury or like scar tissue, um, as a reason why they don't have any hair there. So, um, again, if you are touching this individual's leg, if it's cool to the touch and you can feel or not feel but see that lack of hair loss, you're going to be worried that this person has some sort of peripheral issue. Again, with the combination of the ulcer and the pain while resting and the hair loss and the cool skin, it's going to strongly suggest peripheral artery disease. So going into a little bit more depth into PAD and PVD, peripheral vascular disease. It's an umbrella term for both arteries and the veins. It really is going to refer to any sort of disease of blood vessels that are outside of the heart and outside of the brain. Um, it's PVD affects all of the peripheral vessels, not just, you know, the ones in your legs. Um, PAD has kind of more specific symptoms than PVD, which are going to be caused by whether it's arteriosclerosis or chronic hypertension, stuff like that. But PAD, these individuals, they have a very classic symptom of claudication, which means that they have leg pain with cramping and walking, um, and then it'll stop. And then they'll get it to when they're just kind of resting and their legs are straightened out. They also will have non-healing foot ulcers, shiny skin on their shins or top of their feet, the lack of hair. They'll also have weak pulses, and cold legs and feet. Remember, PAD is for specifically just the arteries. So arteries are taking blood away from the heart. There's an issue with getting blood to the peripheral, and most distal portion of the body, like the legs. And then PVD is going to include all of the peripheral vessels. Okay, so going into the full last part of this lecture. Again, if you don't think this is something you need, go ahead and click off. But I wanted to give you guys at least background information of what the QRS complex is, what is a prolonged QT interval, what's an ST segment. It's a lot of words. Let's kind of get into it. So basically, when we see one singular beat, it's going to tell us a lot about our patient's heart function. We have the P wave. It's this very first section here. And it is the atria squeezing and pushing blood into the ventricles. So this little hump here is it pushing into the ventricles. Now, when we're actually reading this, we're not just going to go, oh yeah, this one looks a little bit different than the last one. We're going to use things called calipers. I know that sounds funny. But this is a measurement tool for us to get an understanding of how long these segments actually are. Um, if you are curious of what they look like, you can look up an EKG. I forgot what they're called now. an EKG caliper. But it literally almost looks like, that little drawing compass that you had in like middle school with like the two sharp little or like the one sharp little point. It's like just two of those, and that's how we measure. But going back into this. QRS complex, it is going to be based on the ventricles and how strongly they're going to contract and send blood to the lungs or the rest of the body. And then we have our T wave, which is that last section of it. And it's kind of the ability for our ventricles to kind of rest and relax before going into the next beat. So our QRS complex, it's kind of this section. So when we talk about our Q interval, actually I have a slide. Let me wait. So P wave, it's atrial depolarization. QRS complex, atria at this point should be repolarizing. Ventricles are depolarizing. T waves are the repolarization of the ventricles. And then our QT interval is from the start of that kind of dip for the beginning of the QRS complex into the very end of the T wave. And this is going to specifically show you ventricular depolarization and repolarization and kind of how long it takes to do that. There's also a PR interval, and this is the time it takes for your heart to signal travel from the atria to the ventricles, or time it takes from a signal to transmit from the atria to the ventricles. Then we have our ST segment. Um, it's going to be right here. I talked about it before when we talked about a STEMI. A STEMI this is normal to have this flat line, but a STEMI is going to have this ST segment be elevated, and then an N STEMI, this is going to go down in a loop. All right, but that's going to show how much your ventricles are squeezing and holding the pressure. If you see, um, well, I'll explain. So again, QT interval, it's the entire cycle of the contraction and recovery from the very start of the QRS complex to the end of the T wave. So you've heard me say QRS complex like a billion times already. So the QRS complex is the most powerful portion of our beat. So it's a very sharp spike in the EKG. Again, it represents ventricular depolarization. And this is when the electrical impulses are going to travel through the ventricles, cause them to contract, and then pump the blood out to either the lungs or the rest of the body. So when we're talking about our pacemaker, hopefully this is starting to click a little bit more. And then its normal duration when we're measuring it with the calipers is going to be 0.06 to 0.01 seconds. Also, make sure that you do know that a widened QRS complex, so something that's greater than 10 seconds, is going to show that conduction abnormality, like a pacemaker issue. Um, like a bundle branch block. So our bundle branches, even though they don't pacemake the heart, they can still have blockages and cause conduction abnormalities, and you'll be able to see the actual abnormality on the EKG. All right, so our ST segment, that's this portion right here. This is the injury. So injury, that is, the STEMI. This is elevated, right? Um, and with that STEMI, remember you get that troponin release because of that injury to that cardiac tissue versus ischemia. This is the ST depression. So this is our end STEMI, that partial blockage versus poor oxygenation, full blockage. All right, so Make sure that you know that this isoelectric line right here at the end of the QRS, it's called the J point, to the start of this T wave is the actual ST segment. And then again, it's the plateau phase of the ventricular contraction. So calcium right now is still maintaining its depolarization. All right, so um, prolonged QT intervals, they are a sign of dangerous arrhythmias like torsades. We've mentioned that before. Again, QT interval. So if this is really long, we're worried about torsades. In men, a normal QT interval is 440 milliseconds, and then in women, 460. And a shortened QT interval is going to happen a lot of times with hypercalcemia, so too much calcium in the blood, because calcium channels are the ones that are regulating the conduction in the heart. So if you have too much calcium, it's going to cause it to fire a little bit more. Okay, so again, here's the big difference between a STEMI, you see that ST elevation, really, really high, versus an NSTEMI, they are depressed right here. Okay, so looking at the actual injury itself, when I say full thickness versus partial thickness, again, full ST elevation is going to be a reflection of something called transmural infarction, which means that the injury is going to extend all the way to the epicardium. So from the endocardium, that inner lining of the heart, through the myocardium up to the epicardium, the very outside, right before we get the pericardium, that sac that surrounds the heart. Versus an NSTEMI, it's partial thickness, so it reflects just the um, subendocardial, which is just a partial thickness in the myocardium. The myocardium is broken up into different sections, but subendocardium is right ab above, or it's sub means below, but right above the endocardium, but not fully through the myocardium, just a portion of the myocardium, which is why we call it partial thickness. And then remember, if someone is having a STEMI, they need immediate reperfusion. They'll get thrombolysis or a PCI. And then for an NSTEMI, it's going to be urgent, but it's not always necessary to do reperfusion in these individuals. So the biggest things that you need to remember for your test, elevation is a STEMI, depression is an NSTEMI. Now that you guys have actually seen that on an EKG, hopefully those things will make more sense. A normal heartbeat, that range is 60 to 100, and the heart has its own electrical conductivity that is based on calcium channels, not like the nervous system, which is based off of sodium channels. Um, well, they also have calcium channels in the nervous system, but it's easier for you to remember sodium with neuro. Trust me. Um, okay, QRS complex. You guys don't need to know for this test the duration of the QRS, but make sure that you remember STEMIs, they need reperfusion. Alrighty, that's everything I have for you guys today. Make sure you watch the respiratory lecture where we're going to talk more about orthopnea, dyspnea, and some of those other things that you can get.